All right, everyone, welcome to Connected Home Health, Closing the Last Mile Gap. I'm Whitney Cole. I am the VP of Marketing at No2, and I am joined by three incredible leaders today. I'm excited to welcome them to the stage. Our topic today is home health, and home health is about keeping patients out of the hospital. Too often, though, what happens is information doesn't flow to the right people at the right time, so patients slip through the cracks. Today we're going to discuss why care in the home depends on seamless information exchange, what's broken, and how to fix it. I'm going to pass it to Therasa first to introduce herself, and then we'll do a couple intros all the way down.
Hi, everyone. Thank you for participating. I am Therasa Bell. I sit as the president and founder of No2, and I am accompanied by two great partners and look forward to the conversation today.
Thank you, Therasa. Hi, this is Aashima Gupta. I'm the Global Director for Healthcare at Google Cloud. Happy to be here.
Hi, everyone. I am Samira Singh. I'm not Amy, if you saw the slide a few minutes ago, or a few moments ago. I am a Senior Director of Interoperability at WellSky, and I'm super excited to be with all of you today.
All right, so Samira, we're going to start with you. When you think about closing the last mile gap in home health and post-acute, what is broken today, and why is now the moment when interoperability can finally scale?
This is a really good question, and I'm so happy that the group before us talked about 360X and referrals and so forth. So maybe I won't say that anything is broken, but I will instead say that there's a lot of opportunity to streamline things, make them faster, to ensure that patients are getting care as quickly and as efficiently as possible, and to reduce administrative burden tied to normalized processes like fax, direct secure messaging, having to pick up the phone, and so forth.
Therasa and Aashima, do you have thoughts on that?
I will piggyback off of what Samira said. I think there's opportunity once we get past the connectivity stage, which where we're at right now with connectivity and connecting the home and connecting the providers in the home. We know that there's an opportunity to advance things with workflows that sit within the referral workflow, and once the patient's admitted, the ability to transition the care plans, the orders for signature by the provider, but also to connect the data that's being collected in the home. Once the patient's being seen in the home, what can we do to collect the data, make that available to the outside community? We always talk about the data coming into the home, but also making that data being transitioned out of the home, make it available to the community. So there's a huge amount of opportunity. And now, why is the time? It's a perfect storm. We are now $32 billion of investment into building a nationwide infrastructure that I would say home health gets to take advantage of with all the national networks and the national activity that's in place, but also the perfect storm of market activity. We have, for good or for bad, we have headwinds that are coming in, and we know that healthcare has to make some changes, and that headwind is putting pressure on all parts of the care segments, including home health. And then we have market tailwinds. So the opportunity with AI and with some of the other technology innovation that we see coming forward, with data moving at scale and all the infrastructure build, now is the time that we can see home health really change the trajectory where it's been a long time battle. We know that intimately, but now we're here and we're really excited about what the future holds.
Just piggyback on that, as an industry, we believe inpatient is a failure of outpatient. Outpatient is a failure from home health. And home health is where community health efforts need to take root. So if you think about a patient journey from outpatient to inpatient to community health, I think what does not work well is the transition, and that's where the context gets lost. Last mile is the hardest problem to solve in healthcare. And to me, we are in a moment now with AI, with data, to be making it a connected journey. And I'll give you a consumer example. How many apps do you think, as a consumer, do you use for your healthcare today? 1, 2, 500, over 100,000. How many of those apps actually connect interoperability to your patient data? Less than 2%. So the opportunities to not create more experiences, more AI experiences, of course, we will create those, but if they're not connected to the data in a meaningful way, we will just create more silos, more experiences, but not interconnected. That's why this connected health topic is center of how we will change healthcare for good. And I think that's the moment now. I think now technology is there to make it easy, to make it seamless. And
So, Aashima, why then is Fire native clinical platform critically important?
I think we need to speak the same language in healthcare. I would say FHIR is a data exchange, but if I'm calling a patient, you're calling a member, you're calling it MRN, we're saying the same thing, but speaking different language. So FHIR, there's a lot of work. I've been involved with interoperability for a number of years now. We finally have a standard to be able to exchange information, and that's where FHIR becomes that lingua franca, a common denominator. And if you're bringing AI into the clinical workflow, if you're not speaking the same language, we're not going to be, completing the full loop from the patient perspective. I believe FHIR and exchange makes sense. FHIR as a platform to convert everything from your native formats to FHIR is a hard problem. And I believe now with AI, we can really fasten that journey. And these frontier models, when we have Gemini, it's multimodal. The context, the understanding, the reasoning that these AI models have is so sophisticated that they will understand the patient context without it being in a very structured format. But exchange, as you're thinking, I'm a payer, you're a provider, or a patient, or an app, we need to be able to speak same language, and that's where FHIR comes in. Frankly, without that, we will create more silos. We'll do one-off integrations, which will not scale, and healthcare has a scale problem.
Samira, I'm coming to you. I want to shift the conversation slightly about what it takes to build interoperability into an enterprise. So a lot of organizations adopt more of a fragmented approach where there's many, many vendors involved, and it becomes unscalable, to Aashima's point. Can you tell us what it takes and what it looked like at WellSky when you were building interoperability as an enterprise-wide strategy?
Yeah, I love that. So I think in interoperability in general, we talk about silos a lot. And there's a lot of reasoning behind that, right? If you build something in a silo, it's going to cost more. If you build something in a silo, it's going to be brittle. If you build something in a silo, not only from a tech perspective, but from an operational, from an onboarding, from a people-centered perspective, you are going to lose, right? You're going to lose time, money, effort. When you have downtimes, you're more likely to have failures and so forth. And so I'd like to tie my response back to what Aashima said about FHIR and a data standard and what it takes to build a FHIR native liquid ecosystem at scale within an enterprise. So WellSky, if you all saw on the A slide a few minutes ago, is pretty massive. We have presence in all 50 states. We have a few different EHRs. We're focusing on home health today. Across home health, we have a ton of customers, right? All of those customers have their own independent workflows, their own documents that they'd like to capture, their own ways of approaching patient care, referrals, et cetera, right? But something that can unify us is taking all of that information and centralizing it within a common language, as Aashima mentioned, right? And from an enterprise perspective, what that entails is building a clinical data repository, cloud native, FHIR Central, or Cloud Central, FHIR Central, Cloud Native, either way, both work, right? And ensuring that across the spectrum, ensuring that you have privacy, consent, HIPAA, security, et cetera, all at play, but that you can capture information within a common format, within a common repository that allows you to essentially exchange at scale. And a part of that also is having a common approach towards security, having a common approach towards onboarding, having a common approach towards getting your customers on board with TEFCA and care quality and other components. And what happens when you do that is you essentially are able to build and support an ecosystem where you build something once and then you scale multiple times. You save money, you save effort, economies of scale becomes a factor, right? And so it's no longer a conversation of, well, Dr. Smith wants to exchange this, and now we're talking about referrals separately, and now we're talking about another use case, right? We have standards pretty stringent data-driven standards in some instances to be able to support this at scale. And it benefits the enterprise when you do so. It benefits your customers, right? It benefits, Theresa talked about the network approach, the clinicians and hospitals and practices that you want to be able to share data with if you're adhering to data standards, right? And so at the end of the day, there really isn't any other approach. If you're a multi-hospital, multi-practitioner, multi-org, vendor, health system, payer, et cetera, you need to ensure that what you build once can scale to everyone else, right? Otherwise, you're wasting time, money, people, effort, et cetera, and you're creating a process that you're going to have to deconstruct and rebuild over time if you don't take scalability into account on the onset.
So you touched on the model, and we have it up here on the screen. The model is a nationwide communication gateway, an enterprise system of record, and a FHIR-native clinical data platform. Tell me why that model works, and if one component is gone, what happens? And I'm going to come to everybody, but we'll start with you, Samira, since you have the mic.
I want to be very ominous, one component is gone, everything fails, right? But in reality, that is true, right? So if we look at Know2 as our connected partner, right? They provide a gateway for us to be able to onboard once. And if you all are familiar with TEFCA, the Trusted Exchange Framework and Common Agreement, that's the entire premise, right? Nationwide interoperability, onboard once, access to everyone else. Know2 as our partner gives us that, and not just as it pertains to TEFCA, but as it pertains to fax and direct secure messaging and so forth. If you take that away, what you're left with is point-to-point connections. You all have experience with point-to-point connections? Yeah? Okay, lots of nodding. So what happens if you build something once with one partner? The next partner comes along and you have to redo it, right? And then you have to redo it again. And then all of a sudden you have multiple contracts that you're supporting and multiple workflows. And then after a period of time, you can't really keep track of what's happening, right? So the process becomes brittle again. So if we didn't have our partnership with Know2, that process would grow to a certain extent, that point-to-point connection ecosystem, until it broke. And then we have to, as I mentioned a few minutes ago, we have to go back to the drawing board and say, how do we rebuild this in order for it to be scalable so we can save time, effort, money, et cetera? That second piece, the enterprise system of record, I am a really big fan of FHIR. Like Da Vinci, FAST, ONC, ASTP, regulation, true believer, right? In post-acute care, there hasn't been as big of an impact over the last decade. When we talk about meaningful use, PQRS, et cetera, post-acute care has not been heavily involved as ambulatory and acute have, right? And so what do you do in that instance? How do you ensure that you are, in fact, supporting a common data set that meets data exchange requirements, that allows you to be successful within this ecosystem? Well, you work with your partners, with your customers across your different software, your apps, and so forth, to ensure that they have the ability to capture and share information with a common designated record set that can then be fed into that last piece, which would be your clinical FHIR repository. When you think about this, right, obviously FHIR is super popular. It's the way of the future. It allows us to be able to target very direct, discrete information for exchange instead of focusing on, oh, I see HL7 people in the crowd. Eye contact. Okay. But instead of focusing on documents-based exchange where you have hundreds of pages, right, at start of care, and then you have nurses and clinicians that are looking at each individual one. And yes, you absolutely can layer AI on top of that, and I think that's extremely powerful. But by leveraging Google's FHIR server, we can also ensure that that information that we care about across those disparate instances is stored in a common way, that we can validate it against various profiles, US core obviously being baseline, right? And that as the industry moves in that direction, we have the ability to exchange information that is tailored to those clinicians, to those community partners, to those cross-network partners that need it at the start of care. And what does that mean? That means that patients across the board are getting access to care faster, better, and that those clinicians have access to information that they need at point of care instead of having to pick up the phone and call someone and ask for additional records, right? So really, I was trying to be a little dramatic when you asked the question, but I feel like within this ecosystem, you absolutely need all three, and all three are enablers in different ways, and all three really allow you to function in a way that I would say interoperability is intended to.
Let's get Aashima's take, or Therasa. Get yours.
There's not much left to say there. I think that was pretty fantastic. Other than I often hear the analogy of, Therasa, we've been working on interoperability for 3 decades. I don't want to say 3 decades. I haven't been. It's 2 decades for me. But we've been working on it. Why isn't it solved? And I hear the analogy of the ATM network. If I hear it again, I'm going to throw something, because it has nothing, there's no relevance. And the ATM network works, it works between financial systems. They're also working with a data set of 0 to 9. That's the data set that they're working with. And when we talk about healthcare, and healthcare being such a wide word, and now we're going to bring home health into the equation, we bring therapy into the equation, we bring behavioral health into the equation, our data sets are exploding, which is where obviously Google's piece come in. But interoperability is hard. And it is a hard equation, and the biggest mistake that the industry has made is trying to solve the entire interoperability equation in one pass. And what I love about this model, and I'll give a shout out to WellSky in this, is that they've taken a different approach with interoperability, and they looked at it as a multi-part equation, as Samira touched on. So they looked at connectivity at scale, which is brought by No2. They looked at the data magic. I always say the data magic is brought to them by Google. And then the system of records, where the creation exists, and they looked at it as a 3-part equation, a multi-part equation. And by bringing the best of breed together, they have flipped interoperability on its head and have moved mountains to push ahead of where they are today. So it's the right way to approach it, especially for enterprise organizations. You can't do the whole equation in one pass. It's impossible. You have to look at it as a multi-part equation.
I think fantastically said. From Google perspective, I've been driving interoperability for more than a decade now, even when I was in Kaiser. And being part of even the original FHIR standard. The fact is interoperability is hard. That burden is easy to make rules, it's very difficult to implement those rules. We believe as a cloud company, as a technology company, our role is to ease and bring those tools to make it easy to enable interoperability. That's why when we started with teaching cloud a language of healthcare, meaning the FHIR server, it was not an easy decision. It's an investment that, okay, we need to invest in how the healthcare organizations will exchange information. We all have, I don't know when was the last time you went to get your record from a physician office? I think back in 2017, I needed one. I got a CD drive. I didn't even have a CD slot in my laptop. And this is why when you're seeing patients in their most vulnerable moment, when they need access, maybe they need second opinion, maybe they need to get to a different expertise, we are giving them tools from 20th centuries, CD drives. Now you figured it out. I had to go to FedEx, convert it into, I think that's now how we will empower patients. We often talk about empowerment of patients. Make it easy for people to take care of their own health. And in that, people don't need FHIR, right? As a consumer, we need access to our information in a standardized way. So not only that the data is in FHIR, it is an API, electronic transmission of that information, so that I can connect it to any app of my choice with my consent, so that I can either seek an expert opinion, get into my entire patient history, my timeline. That's what the essence of FHIR and interoperability is, consumer empowerment. On the flip side, there's also physician empowerment. We are sending CCDs across the fence, multiple pages, as Samira said. How do they show up in the clinical workflow? As I'm pulling up the patient, it's a completely different clinical repository, lives in a different system. So we make it very hard for clinicians to take care of patients. We put all that burden on to either patient or to clinician, and with this archaic standard. Good news is now with AI and the guardrails that we have very thoughtfully put together, the CMS, huge kudos to them for interoperability pledge. I was with the CMS maybe 4 months ago. There are 700 applications now leveraging Fire Standard to be able to exchange information. Different use cases, they will keep emerging. What doesn't change is the common language. So to me, the ecosystem you're seeing is a kind of reflective of how the industry will move forward. There will always be the data storage, API access, the gateway to be able to get the information, and then system of record. All this works in harmony, but the rails, the standardization is that foundation in which we will build many experiences like that. So my kudos to WellSky to really take it head on from the post-acute perspective and for the community gateway that you are building together. These are hard, gnarly problems.
All right, so I think we have time for one more question. Therasa, I'm hoping you can make this real for us. So I would like you, if you can, to give us a real-world example of what it looks like when interoperability breaks down, but also when it works. If you have an example of a patient, or if you have an example of like a provider.
I can get personal on this one. So my father is a 85-year-old Parkinson's with advanced osteoporosis. He has broke both of his hips. He has broke his femur. He has 6 fractures in his back. And I have had to experience it multiple times in care settings when he has been with either one of his hip fractures, with his femur fracture, with his back. He's had acute care transitions into the skilled facility, into the inpatient rehab, and also back to the home with therapy. And inevitably every time, and this is why I have the company I do, is I'm going to solve this problem before I die. I promise all of you, I will solve this problem. The transition of care failed every time. And to the point where it was from the acute care facility to the skilled facility, which was actually part of the healthcare system that he was in. They didn't have any of his medications. They had nothing transfer over, and they almost prescribed him something that would have been counteractive to his Parkinson's medication. It would have had a significant impact. We caught that. He had an outpatient transfer back to his neurologist, who was also his primary care doc, that she had no idea. He just happened to have a reoccurring 3-month appointment. She had no idea. She was a wonderful person. She had no idea that he had a recent acute care stay with an inpatient rehab stay and now had home health services. So we go to see her, the Parkinson's doc. I'm filling out a 12-page questionnaire. And about page 3, I said, I'm done. I'm not filling this out anymore. So I went back up to the front desk and I said, you're in the health system. They happen to be part of a health system in Minnesota. I know you're on the backbone of the actual electronic health record. I need you to go look in the system. They didn't know. I won't pick on any systems here. She didn't know. And so I showed her in the system. I said, you can go see his entire record. She didn't know that. And so it was just a complete failure of the healthcare ecosystem. So then I went through it with her and I said, what if at the experience, instead of my having to go in this reactive engagement every time, take the neurologist visit, for instance, if they knew not only that this whole incident occurred, but that they had something prepared in advance, and what a different experience for the patient. What if she was proactively reaching out to him after the visit? I mean, there's just so much opportunity, and we always talk about what we could do with the current healthcare system that we have. Think about what we can do to transform healthcare. So as care in the home, we always talk about it as post-acute. We shouldn't be using those words. It should be, I think she started out by saying that is a failure. If we have an acute event, we have failed, something's wrong, and we need to look at it as a pre-acute. We need to look at our opportunity to keep care in the home, but the only way that we can do that is drive meaningful workflows, meaningful data to those that are caring for the patient and in the home, making that aware to the rest of the community. So I think the opportunity is immense to fix what we have, but imagine a completely different future.
Cool. If you would like to see this in action, you can come by the No2 demo space. We're right over there. WellSky is demoing with us. We'd love to see you. We have our next demo at 2:15 today, so hopefully you'll come by. And thanks everyone for being here.